This is the Situation Room, the only way to start your day.
Studio this morning, quite some sticky stuff going on, right? And we're going to try and unpack that and figure out exactly what is happening and what exactly it means. But before we do that, Dennis is going to welcome you with today's proverb. He'll tell you where it's from. We'd love to get your interpretation of it.
Yes, the proverb today comes from Botswana. Botswana, a country that hosts the Kalahari Desert, and as well has a salt lake, that is beautiful because of the flamingo migrations. It's a world phenomenon there. But then again, if you also want to enjoy a different type of protein, they have worms that they harvest from the mofane tree. So yeah, worms is a delicacy and a protein in Botswana.
Yes.
Umesema papana. But another thing that stands out here is they've maintained the traditional chieftaincy system of managing local communities, and that is recognized by the state. So it just helps devolution, in that country, and ensuring that everyone feels part of it.
Unfortunately, in that system, I've never seen a woman chief. It's always the man.
That's interesting.
Yeah.
In Nigeria, we have the same thing, but you see a lot of women chiefs.
Women chiefs, yeah.
The women chiefs in Nigeria.
Yes.
Okay.
Do you still call them Oga?
Oga is for men.
All right, so let's go to the proverb, right? Now, if the cattle die, the people die. If the cattle die, the people die. How would you interpret that? Go ahead, first.
Thank you. If the cattle die, the people die. I could interpret it differently and in many ways, but I want to bring in from a perspective of where we are currently and what is happening in our nation. And I want to use an example of a healthcare system. When SHA is not working, the country is on its knees. That is how I could simply interpret it.
Well, straight into the fire, right?
Yeah.
Dr. How would you interpret it?
I think I get this sense of interdependence of the two. And if the cattle die, perhaps where we get our nourishment from milk, meat, and many other things, then we are not able to eat. And if we die as well, we're not able to take care of the cattle. So there's a sense of symbiosis in it, and relying on each other. Yeah, that's how I look at it.
No put.
Yeah.
Absolutely.
Yeah.
Kind of depend on it all, don't we? And then one thing we do depend on then is our health. That is for sure.
Oh, yeah, for sure.
Because if we're not healthy, then, there's a lot left. Universal health coverage is a promise. It didn't start with this particular administration. It was one of the big four agenda in the previous administration, which carried on for 10 years, right? We saw that the big four agenda was carried heavily by the Uhuru Kenyatta administration in his second term. And so we looked at those four. There was housing, there was universal health coverage, there was food security, and there was one other I can never remember, but those are the big four. But health rang through. We've also seen health come out in this administration. The William Ruto administration has insisted on universal health coverage. Now, we say it's not health care, we say it is health coverage, because then it's all encompassing. And so we are dealing with your treatment, but also looking at the welfare of health workers and all of this taken into consideration. And then NHIF was to be the driver of this. And soon it became to realize that NHIF was not going to be able to do that for whatever reasons. And then the Social Health Authority then was established. We've now called it SHA, and we kind of use it as a buzzword for whatever it is that we do. And so things have been happening. The contribution has been demanded of Kenyans. You make this contribution, put it in a pool, which is the idea for most health covers the world over. Everybody gets into the pool. It does two things: is that it spreads it across the population, and then it makes it more affordable because everybody is essentially contributing to this kitty, and then the government doles it out. So if you don't have enough people contributing, you're not able to deliver. But beyond that, now we're seeing that it was put into 3 tiers, maybe 4 for argument's sake, but 3 tiers generally that we look at. Now, unfortunately, the tier that government should be paying for seems to have a bit of an issue. We are not quite sure what's going on, which is why both of you are here this morning to be able to explain to us what's going on and what does then that portend. We've seen many announcements. The most recent was that civil servants will now have to pay out of pocket when they go to access medical care. Let's start with you, Dr. Theory. What is going on?
All right. I'll just begin with a short introduction of myself. I am Dr. Theory from Kenya Healthcare Federation.
Yes.
And what the Federation does is we are the umbrella body for the private sector in health, and we oversee the entire value chain. And we do also serve as a health board for KEPSA, that's the Kenya Private Sector Alliance. So that's who we are. Our main interest is optimizing the relationship between the patient or the people who are seeking care and places where they seek this care from. And it being in the private sector, of course, we want it to be an enabled business environment, and responsibly so. I always insist on that. So I think at some point last week, we did issue a notification for distress. We haven't got to the point where we are saying it stopped, but we issued a notification for distress, and the alarm bell here is the civil servant scheme that is, I believe, procured by the Public Service Commission has not been sustainable from our end. So we are issuing a notice for distress, and we are not saying we are not able to do it. We just cannot anymore. It's not sustainable because of payments are not coming in as we would wish them to.
From whom?
From the Social Health Authority, because they are the ones who are managing that particular fund. So it's a fund separate from the three funds that we know of. And the public service kitty, or rather the one that takes care of the civil servants, is the one that is currently the conversation.
Okay, please just so that we can understand exactly what's happening. So there's the 3 tiers, of course. There's 1, 2, 3. Everyone has its different. Then there's this one that was supposed to take care of civil servants, police, that fund. That money, where does that money come from for that fund? From government directly?
So, we do have the 3 funds: the social health insurance fund, the private healthcare, primary healthcare fund,
and then critical care,
the emergency critical and chronic illnesses fund, and then we do have the, let me call it a special scheme that they manage for the civil servants. So that is procured by government under the Public Service Commission on behalf of civil servants. They will enter into a conversation with SHA on all the benefits for the people who they are procuring this for. Should be. And it's also elaborate because it's what was previously managed by NHIF. Now, we are not seeing payments under this particular scheme come in as we would want them to. Providers, or rather the hospitals, are the ones who underwrite the promise that the government has given to Kenyans of universal health coverage. And if that promise is not underwritten properly, then we do have situations as we do right now happen.
So essentially, what would happen is that anybody who works for government.
Yes, anyone who works for government. There are also access rules to it. I don't want to believe there's a particular job group which you must belong to and above.
In order to access this.
And in those various categories, there are benefits which you're entitled to. So there are those rules to it.
So essentially, you would show up with your card or your registration, whatever. You go to a medical facility. They should then be able to treat you at no further cost to you.
Yeah, you're identified as a civil servant, and automatically the system will pick the benefits for you. I am a proponent of factual reporting. SHA has been paying on the 14th. Every month, which is a good thing. There's predictability in the time in which they pay. They are what we call submitted claims. They are what we call what they have verified. After a claim is submitted, it goes through adjudication, and at the end of that process, the output is a verified claim that is deemed payable. And then there is what is actually paid. So there's a discrepancy between the verified and what is actually paid, and that difference is now what is the debt that SHA owes providers.
Why would they pay something less than what has been verified?
There could be a couple of reasons.
Okay.
And you see, right now, we can only speculate because the fact of what is coming in terms of payments, in my opinion, we hear it through media conversation. So last I heard is about 46.1 or 41.6 billion is what has been paid out so far. Since October. We do have about 93.5 billion in submitted claims, out of which about 83.3 billion is what has been verified. So we still have a gap of more than 40 billion that is yet to be paid out. And this is more than what we even accumulated under NHIF. The contractual period for payment is 90 days. So if all this is cleared within the next 90 days, then there's no problem. All right. But I'm a student of history as well and patterns. And the story still remains the same. And from, I don't believe May, there's been a decline in the claims volume that was there. In May, we had about 13.4 billion in terms of claims. In July, that dropped to 9.6 billion. What could the story there be? One, the provider network is a little jittery, so there's holding back. Because if your SHA exposure is anything more than 20% of your business, then you have a huge uncollected amount. So as a business owner or someone who's running a facility, even at county level, that's a big exposure because the margins are razor thin.
Okay.
And if your margins are razor thin, then it means your obligations as well do not stop. So that is the conundrum where providers are in. And about 56% of our case being offered by non-state actors. And in way of numbers, out of that 93.5 billion that I mentioned, non-state actors contributed about 64 billion in terms of these claims. Government-affiliated facilities were about 29.3, so give or take 30 billion. So there's 2 times the number of claims from the private sector. In terms of the transacting providers, about 10,611 as of today morning. And out of this, the parity could be about 50-50. But you can see in terms of the claims volume, it's nearly double on the private sector side. The story here could be that more people are perhaps seeking care on the from non-state actors, or there could be a higher value procedures that are being done by non-state actors. That could be the story there.
That could be, okay.
Out of that, 57.5 billion is what has been verified for the private sector. And the claims volume here is about 3.2 million claims against 1.3 million claims for government sector.
Okay. Well, now, Charlie, what does this actually mean then for folks who are then presenting themselves to hospital from last week when we saw this announcement being made?
Actually, it is so devastating, and it has come clearly from Daktari that when you're serving the nation, you're a public servant. But when policies are implemented, they implement for civil servants. Okay? You see the discrepancies?
I see it here.
Policies are at the national, where they implement. But at the counties, because we have a government and we have governments, and then they say health was devolved. So at the county governments, we are perceived to be public servants. And then the implementation is totally different. So the policies and the so many letters that you see going across, they're at the national government. No implementation matrix at the counties. As of last week, we had to bail out one of our colleagues from a private institution. And yet, she's working for a county government, remitting, because it is a statutory deduction from her payslip, but then it is not remitted by the employer. She had to be retained in a hospital, and we had to contribute to bail her out. So when Daktari says that, yes, they have issued a circular, not to, but they're headed there, then from where we sit, we do not experience it.
I think the clarity also that at what has been said is, one, healthcare is not free. There's no free healthcare. Someone has to pay for it. And that's the one thing we must all agree as Kenyans. The second level of questions after that is who pays for it. All right? Government has undertaken to offset part of that. All right? Then it means where does it where is the balance coming from? There has to be an aspect that we agree with each other that, one, as Kenyans, we must de-risk ourselves when it comes to catastrophic health expenditure. And there are a couple of ways of doing that. One is through insurance schemes, and the social health insurance is the largest strategic purchaser for health. There are benefits therein that have been offered. And upon registration, you're entitled to those benefits. What I do want to see happen is the insistence of payment of your premiums after registration. Government needs to be very clear on that. Our members of parliament need to tell Kenyans it's not only important to register, but it's important to be a paid up member so that the fund sustainability is guaranteed. As of now, we have, I think, more than it's north of 24 million registered people. The contributors who are actually paying are less than 6 million. All right. So at the end of the day, adverse selection is still happening. What is adverse selection is I only pay when I am sick to access the service. Yet remember, this is a social, it's underwritten as it being a social scheme where those who have more contribute a little more than those who cannot. And that is, and I think that is a lesson here. The second thing that we must understand for any social scheme that is being run, and I think China presents to be a good example of that, is there has to be trust on both sides, where the citizens trust that the government is going to deliver on their promise, and the government trusts that the citizens are going to pay their premiums. That has been lacking. And it's something that I'd want to urge our leadership to really look into, because that is where the rain starts beating us. As the private sector, we are saying, we want to see this work, because there's no day we want to see a sick nation. A healthier nation is good for both sides of economics, yeah? And this is me not being, I'm not being brutalist in my view of things. It's just letting Kenyans know the healthier you are and the longer you are healthier, the better for everyone around you. All right. So our health expectancy must be increased by the right health economics.
So I'm trying to see if that has been already established, that like with any health pool, that the more people you have, then you have now able to make it accessible to everybody. It's like taxes. Yeah. You have more people in the pool, then it makes it easier for everybody who is in this pool. But then, like now, what Bonanchari was saying is that, you know, you get somebody who's sick last week and then they have to bear the brunt of this suffering because that's the situation. How do we get out of that? How do we solve the problem? Because we've established this universal health coverage. You can say that you go to hospital and you use your card and it's free. It's not really free. Somebody has paid at some point for that to happen. How do we then break this thing? Because it seems to be the bane of this health system forever, whether it was NHIF, whether it is now SHA and SHIF, whatever the case may be, at whatever level, somebody has to pay. And if not enough people are paying, we have that situation where people are going to go to hospital on a Monday morning and they're not going to be able to access healthcare for free. They're going to have to pay again from their pockets. Is that fair that there has been a deduction, statutory deduction? I should actually access this thing when I go to hospital, but then I'm now having to pay out of pocket again because the fund is empty.
I think that is the situation that we are in, and that is what I was trying to elaborate to Daktari, that the implementation matrix on this whole scenario of the medical scheme has not actually been as it is on paper. And then the number two, how the whole structure is. I equally understand that from where I sit, and even with the three levels of how the scheme has been categorized, it depends on the kind or the nature of the service that I could want to receive. You're in a county government, you understand very well that there are no structures put in place, and yet that client requires an ICU. That client will not go to a level 1 to start from there as it has been structured, will move straight to level 5 or any other facility, including private institutions, where you'll access that service. So the mode in which this client will be categorized is not as in how the model on the national government is, which has put civil servants in their own category, including the job groups. We have staff at the county level who are at higher job groups, equivalent to those in the national. But then because of the modalities on how the implementation is, he or she may not be in a position to access the service that whoever now is perceived to be at the service of the civil servant is accessing. Yes. In the national government, we have merger job groups, which gives an opportunity to those who can access those services at that level. And the county level, we have job groups that are not merged. So there are areas where those gaps are. And these are some of the issues that I'm saying. If we have all these, that we have one nation with 47 county governments, the implementation is totally different, then we are missing the point.
Doctor?
If we could be having even well-equipped government facilities, including the county government facilities, then at least we could be talking from a point of, we have a level 5 that is equivalent to a level 3 of a private institution, because we have a level 3 private institution, but when you equate it, it's more of a level 5 coming to a government institution. So why can't we measure on improving our government facilities so that the same people who are working there can actually be given a priority even to accessing those services that they do give, before even thinking of where do we move to next when such issues arise. But the bigger picture and where we need to unlock is, where do we draw the line at this is a civil servant and this is a public servant? That is where they got it wrong, and that is why you're seeing the discrepancies of saying those who are working for the government, at one point we are going to seek services and out of pocket. Number two, they need to ensure that, because there is a circular that by 9th of every month, those monies should have been remitted. Up to now, we have county governments that have not paid the July salaries.
Okay.
So what do you expect? Definitely the system, because it's automatic, it's deactivated.
Yeah.
Then they have those scenarios that they will wait until towards the end of that month, then they pay, then it is active for 3 to 4 days, again it deactivates itself. So for how long are we going to do that? Remember, if a client goes to a facility, he or she is checked in when the system is off, then it automatically will not capture him or her. Upon discharge, again, this client will have to pay, even if you activate it towards the end of that month. The duration that this client has been in the facility, he will or she will have to cater for out of pocket. So we really need to, if these policies must be implemented, then the same government that comes up with the policy must ensure that these monies are remitted in good time, so that all the systems run as they could want them run. Otherwise, we're going to continue saying that we have teething problems until we grow age with the teething issues.
So here's a situation where, Dr. now, it's a circular issue that private hospitals gave, and now we find ourselves dealing with a pool of individuals who, according to them, they have paid for SHA. And rightfully so, they need to access medication or services at the hospitals. But there's a question, you've given your circular. Perhaps these are discussions you've had with the respective governments. And if so, what's the negotiation or conversations you're having with them? Or is it a question of until when there is crisis, then we start discussing?
Like I began by saying, the healthcare sector, it's underwritten by two people. The provider network, those are the hospitals, and the people who work in there. Those are the healthcare workers. If any of those two is not happy, then a crisis begins to brew. And as of now, the crisis that is brewing is there's a lot of debt distress in the provider network. I am in a group of about 900 providers. And there are conversations every day of people getting auctioned, of suppliers knocking on people's doors, something that we've not seen in a while happening in the healthcare sector. Our contribution to the non-performing loans portfolio, even in the banking sector, has gone up because we are largely a cash flow business. 80% of my businesses that we overlook are SMEs, largely owned by women and youth. So cash flow is king when it comes to this sector. And SHA, being the largest strategic purchaser, should realize that and ensure that we are having the constant cash flows, because we have quite some exposure as businesses when it comes to how we run the operations. That said, SHA is the owner of the promise to Kenyans. We are just the underwriters.
Yes.
All right. Therefore, the primary contract is with Kenyans. And we are the people who facilitate that contract. One of the best ways of ensuring that this happens is working collaboratively with the provider network and with government. And we should have meetings where we touch base every so often. What is happening? What do we do? And we are happy to have these meetings. We are happy to pass the message to Kenyans and say, look, funds, for us to have good fund sustainability, we may want to scale down on a few things, and we are asking that we work together on this. Bear with us as this happens, but the promise is going to get better. That is a messaging that is missing. Because if we do not have adequate funds coming in, then at the end of the day, something will have to give. And economics, like physics, when there is pressure, it has to come out at some point. Yeah. So it is for you to decide how this pressure is going to be released. It can be released by paying. It can be released by having conversations where you actually plan, all right, and say this is what the table looks like, and this is where this pressure is going to.
Have you received any response from the SHA CEO, Massimo Ngange, since you gave out the circular?
We are having conversations. That I must say, Waziri and my chairman have had a conversation. We do know it's a busy week with the devolution conference and whatnot, but I'm really hoping that at some point we can sit down and iron these issues from a very honest point of view with each other. The other thing that I'd like to mention is we do have very many providers who are doing the right thing. And the conversation of fraud, wastage, and abuse is one that I've always championed everywhere that I go, that must stop. Unscrupulous providers who are doing things that are not right, we must weed them out so that we can have the right people getting incentivized to continue doing the right thing and better their practice, all right? So that at the end of the day, the average rises up, all right? And it's something that I'd like to comment. However, due process must be followed, all right? I do understand the frustration of due process. At times, even the bad people can hide behind due process.
Yes.
What I would suggest is, let's have a conversation with government as the providers, where they come and say, we think that you as the ORI are not doing the right thing. And I'm told, okay, this is what we think. And we agree as providers and the government and say, okay, we do agree that there is an issue here. Put this person aside so that it is also peer reviewed and we're able to move very quickly as process again is being followed. The dispute resolution tribunal has not been set up. So in the absence of that, what do we do? Yeah, we cannot keep on saying that fraud is happening, but yet the place we're supposed to these complaints are supposed to be taken has not been formed. So in the interim, that is what I believe we can do. As KHF, we sit down and together with SHA and MOH and say, we think that the following 40 facilities, as Waziri had announced, are not doing the right thing. And we agree, because as of now, it is a one-sided conversation. What we are saying is, for it to be a full conversation, both sides of the both parties must be talking to each other.
Okay.
Yeah.
In countries where we've had these kind of systems work, where you have a government-backed medical scheme, from something I read a few weeks ago, there are safeguards.
Yeah.
My question then is, what were the safeguards when now SHA came in? Because you mentioned there is the 90-day that then you're supposed to start seeing some money coming in. Beyond that, what were the other safeguards?
So they were in various levels. One was that as long as you are registered by the Kenya Medical Practitioners and Dentists Council, who's the regulator for the sector, and that list is provided to the Digital Health Authority and SHA, then as a provider, you are entitled to be contracted. All right. So all you just needed to do was sign a contract. That is a good thing. That's an improvement from what NHIF was. NHIF, you presented your papers, they came and did an inspection, and then you go to the board, and that, I mean, boards statutorily meet every four times a year. Yeah, so 3 times every 3 months. Yeah. So by the time you get the gazettement, I mean, a year could have lapsed. Your situation could have changed. But right now, as long as you're on the KMPDC register and you've signed your contract, then automatically you become a provider. That is a good thing. And the safeguard here is KMPDC has done an inspection, it has approved your facility, and that is quite rigorous. So that is a good thing. The second thing was there's a benefits and tariffs advisory panel, which would sit down, and we've given, as a private sector, we have a nominee who sits on that panel. And they would look at the benefits and the assigned tariffs to them and say, look, this is what we think should go together with this. And that is also one of the safeguards. The other one is a dispute resolution tribunal. Previously, NHIF was judge, jury, and executioner. But right now, we do have a separate body that looks at any dispute between the authority and providers, or between the authority and maybe even the person who's seeking care. So that is a good safeguard, and I applaud it. The other thing is digitization. The moment you digitize the claims process, and you put the claims through the rigors of a rules engine that is derived from access rules and even the clinical situation of the patient, such that your name is not listed as someone who's undergoing maternity care. All right. So the system is able to knock off things that are not right. So digitization is a good thing. So, and I think under the current dispensation, that is the biggest safeguard. However, we cannot also use that as an excuse. All right. So when claims are binned, as they're going through the rigors of adjudication, and of course we can now track where all those things are, which is a
come
good
from
thing.
where they're going.
Yeah,
Okay.
it's a good thing. Yeah, but now at the output point, that still remains to be an issue. All right. So all those safeguards are good. All right. However, at the end of the day, we mustn't confuse visibility for transparency. Okay.
Jerry, I have a question. There's something this morning we were actually looking at a story of, I don't know why my head is still on that story. Still concerning health, mothers at risk as bleeding detectors are running out. What is the number again per day?
21.
21. We're losing 21 mothers on average every day in this country because of this. And the three of us, when we're just discussing this, you're looking at areas of priorities. And it's common sense to sit down looking at this and say, okay, we need to fix this. But as things stand, this is not fixed. From a union perspective, because there's something I always call organized chaos and manufactured crisis.
Correct.
Okay?
Yes.
And I strongly believe what we are seeing here is not something that can't be fixed. I think it's allowed. Somebody has allowed it to persist for whatever reason. But from a union perspective, who bears responsibility? That's where my confusion is with this. So is it, for this particular crisis, is it the SHA board? Is it the Ministry of Health directly? Or is it Treasury? Because people are remitting, like you said. So when it comes to payment is where there's a problem. So I'm trying to figure out, so which layer do we look at here? Do we look at the board of SHA? Are we looking then at the Ministry of Health? Or are we looking at Treasury?
Thank you. And I think the proverb now confirms and brings back the interdependency on the three areas that you actually mentioned, of course, must come in. But the main character here is who are we answerable to the Ministry of Health. So if there is a problem in health, the first person to be accountable is the Minister for Health, so that he can explain to Kenyans the allocation that has been done to health and what it has done. When we say that we're losing mothers, that is something that should not be happening. What is it aiding that we end up losing mothers? Is it because we don't have doctors? Is it because we don't have nurses? Or is it because we don't have qualified personnel to deal with this? That is one aspect. Number two, is it because we don't have the apparatus, including the infrastructure? The infrastructure cuts across from one point, maybe from home to the hospital. Then within the hospital, do we have what is required for us to ensure that that mother and baby are safe? The number three, what are the mechanisms have they put down? Because number one, look at how we're not able to access blood products as previously we used to. The circular came that now don't visit institutions because that is those are the areas that we could access these products because they are not bought. These are something you talk to these are medicine that you talk to Kenyans.
Oh, so hang on. So there's a circular that has come out and says you from today or whenever you no longer visit this particular facility because you will not have access to what
not
you
a
need.
facility. There was a circular that because initially if you look at where we get these blood products is from high school, colleges. Yeah, but then there was a circular from the Ministry of Education that now do not be visiting these high school or school facilities to access these products. For reasons I have never gotten the ego. But then the buck stops now with the ministry. Let them provide what we healthcare workers require. Let them employ adequate staff. And let them ensure that whatever is required in those facilities is there. So that when Dr. Deuri and team is there for an emergency, when Chari and his team is there, the lab is there, and all this team constitutes to one with an aim of saving life of this mother and the baby. Otherwise, when one chain is broken, then the chain is not functional.
Is this the point where then the ministry, if the buck stops with the ministry, where then the ministry will say, our budgets are so constrained, we can't stretch ourselves. Then we go to Treasury. Treasury says, we're not collecting enough, so we can't give you what we do not have. Then the conversation ends there. Dr. Theory, what's the worst case scenario if this crisis persists, let's say in the next 6 months?
I'll begin by saying that the conversation of maternal mortality is one that I have seen. It's not a backroom conversation, and I must be fair to MOH. It's a conversation that has been a headline conversation for them. And I'd like to draw a parallel from what is currently happening in our stadiums. You cannot understand the importance of a whole country being behind you. And we are all backing Harambee Stars. We put our differences aside and we are backing Harambee Stars. It's also time we put our differences aside and back health. I think over the weekend, we unfortunately lost some people through a road accident somewhere in Kisumu.
Yeah.
And we are losing 21 mothers. That's a busload every day. I don't want to drive that home. We are losing a busload of mothers every day. Yet the response has not been what we saw. All right? The permanent secretary dropped down to Kisumu just to see what's happening. But here we are losing mothers every day, a busload of them. When you look at our statistics from maybe even the 60s, there has been improvement in terms of the maternal mortality rates, but they've not been dramatic. All right? I dare say we hadn't even invented CT scans and MRIs. All right? But our changes have not been dramatically different, even with access to technology and services. What we must do is, one, we must ensure that all our mothers are giving birth in health facilities, that all our mothers during the period of pregnancy are accessing a skilled health worker. Those numbers are good. In terms of access, it's about 80%, but you see, the output side, there's a disconnect somewhere. We must improve the suspicion index of our healthcare workers, where our nurses who are taking care of our mothers at the point of entry, the clinical officers, the doctors, we come up with a matrix of what the dangerous indicators are, and we stick to that. The other thing is that all this must be underwritten by available commodities. All right, so drugs that prevent all these things from happening.
Yeah.
So, for example, I think over the last 2 years there was a time where in the KEMSA tendering, tranexamic acid was considered non-responsive in the tendering process. This is a drug that helps in preventing bleeding or stopping bleeding.
Okay.
Yet we have a facility that's just down the road on Mombasa Road that produces it. All right, why not contract them on a rolling basis? All right.
This is the Situation Room, the only way to start your day.